Thank you very much. Good morning. I will be presenting about anesthesia update in pediatric surgery. So I have no financial conflict of interest in presenting this presentation. This is going to be the outline of my presentation. I'll start with introduction, and we will see about anesthetic focus in perioperative care of pediatric surgical patients, and then we will be starting selected topics like preoperative anxiety, clear food fasting policy, and different intra-op methods like we also have an overview on enhanced. So this is my presentation. I have an overview on enhanced recovery after surgery. So children, and to see the different approaches that are used to decrease anxiety in children, and also review different preoperative fasting guidelines and revise where consensus is shifting currently, and also summarize the advantages of pediatric regional anesthesia and discuss controversies towards this. And finally, we will try to see components of enhanced recovery after surgery protocols in pediatric population. So, as we all know, pediatric anesthesia is the largest part of anesthesia clinical practice, and anesthesia-related mortality in children is not that common, especially in developed countries. However, if the number remains unnecessarily high, still in low-income countries, including that of ours, and different anesthesia-related critical incidents, or what we call as the near-miss event, occur in 5% of anesthetic procedures. This is the data from the Western setup, and it's said to be largely dependent on the skill of and on the up-to-date knowledge of the whole perioperative team. So, in thinking of perioperative care for pediatric surgical patients, there are different important topics that should be addressed in the preoperative, intraoperative, and postoperative. So you can see the different lists that have anesthesia updates currently, or those where we are practicing at the minimum of standard care, or which can be also below a minimum of standard of care. Unfortunately, we cannot be able to discuss all these topics in this section. So I have tried to select some of them, like preoperative anxiety, like pre-op fasting guidelines, which are an update, regional anesthesia, which we may not commonly practice in pediatric anesthesia, and the new attention worldwide, like enhanced recovery after surgery. So, starting with perioperative stress in children, we know that surgery is a stressful situation for all the surgical patients, especially for the pediatric patients. It is going to cause stress for the children, and preoperative anxiety in children is said to occur in 40 to 60% of children, and it's going to have a feeling of unpleasant feelings, nervousness, crying, and they will manifest as being a scared appearance. They may have deep breathing, they may be crying, they may soil or wet their diaper, they stop playing, and they may also attempt to escape. It's very common for us, I think, to see such kind of children in our setup. And generally, the behavioral stress on them, it's going to depend on the patient's temperament, their attachment to their family, as well as their cognitive development and their ability to understand about illness. So what are the risk factors that are associated with preoperative anxiety in children? Age, preschool age usually. from 1 year to 5 years are said to be more at risk for preoperative anxiety, their developmental maturity. Sometimes age may not be the exact way to see their developmental maturity. So depends on the different the developmental maturity of that specific person. Previous hospital experience, especially being associated with bad experiences where their pain has not been treated or they have experienced a previous preoperative anxiety, is also said to be a risk factor. And an underlying preoperative anxiety in the child before surgery or even in the parent is also said to be a risk factor, and longer hospital stay is the other risk factor. So what if we don't treat preoperative anxiety? What are its effects? It leads into behavioral stress response preoperatively. So stress hormones are going to be released, ACTH, cortisol, epinephrine, and other hormones are going to be released, and it's going to result in intra of increased anesthetic requirement, also post-operatively. It's going to result in untreatable pain or delirium, anxiety, a sleep disorder. And also, post-operatively, the child may be experiencing post-hospitalization behavioral changes. This could be like nightmares or enuresis, eating disorders, or it can also be like tantrums and stress in the child. So it's said to be to occur in 88% of children, and it can occur up to 4 weeks post-hospitalization, or it can stay up to even a year. So you can imagine its consequence on the child, on the stress, as well as the parents and the productivity in the parents. So can we prevent or treat preoperative anxiety? Yes, of course. We can use different mechanisms. There are behavioral intervention methods like pre-op preparation, which can include teaching children how to cope, or giving them an OR tool, or guiding them with videos, and like that can be one method. And parental presence and reduction is also another one, which can be used to decrease preoperative anxiety. And other healthcare provider interventions can also be done. These are what we commonly do, like it could be distraction or humors, or having like non-procedural talks with the children, or other things like a bundle of care. There is a bundle of care for preventing preoperative anxiety. It's with ignoring of advance. So we need to teach our health professionals regarding this preparation program. So even complementary medicine can come into this aspect. Music or acupuncture and the others can be used. And pre-medications are quite usually used and prescribed in peri-operative care of children to alleviate preoperative anxiety. So this is not quite used in our country, but different groups of medication can be used, including opioids or alpha agonists or benzodiazepines, and a combination of medication can also be used in the preoperative period. So where are we regarding preoperative anxiety? So there is no much data concerning about preoperative anxiety in children, but at Gondar University in 2020, a cross-sectional study was done to assess the magnitude of preoperative anxiety, and it was said to be around 75.4%. And there are some data regarding adult population where the preoperative anxiety ranges from 0.7 to 70.3%. So what are we doing regarding this? So there is different healthcare professionals intervening for preoperative anxiety using their own method. I haven't came out of any guideline that is used in each institution to alleviate this preoperative anxiety, and I haven't seen any consistent use of pre-medications in children as well. So what should we do? We should have a systematic approach for such kind of alleviating preoperative anxiety. We need to explore more on this field, on the presence of preoperative anxiety nationwide, and we need to know also about its impact based on the researches, and we need to be involving parents with pre-op preparation as well as trained health professionals that are involved in perioperative care of these patients, including the nursing, the pediatry, the nursing staff, the scrub nurses, our staff, and also pediatric surgeons should be trained on different interventions and pre-medication. We need to be using pre-medication and being able to use to follow patients who are given pre-medicated in this regard. So pre-medication should be widely available and we should be starting using it. So the other thing is parental presence during induction doesn't always work. It may not always work. So there was actually a systematic review of like different studies that was done in 2008, and it's compared parental presence during induction with no parental presence during induction or with pre-medication, and it showed that there is no decrease in childless anxiety, rather it's more helpful with decreasing parental anxiety. So can we use it in our setting? Maybe, or maybe not. It may not be beneficial that much, but we have to know for the parent and the child dynamics, we have to know what the parental personality is going to be and whether they want to be there or not. And we need to know also where the location of surgery is and if there is anyone who's going to escort the families after induction, and it also depends on anesthesiologist research. So even if it may not be that much beneficial, we can still explore its use, especially for those who have a severe anxiety and who have also parents with monitoring type of personality. We can start using it and see how it goes. So this is about preoperative anxiety. The next is the preoperative fasting guidelines in children. So I think we will have a discussion later on. So concerning preoperative fasting guidelines, as we know, most commonly the literatures advocate minimum fasting of clear foods 2 hours, for breast milk 3 to 4 hours, and for solid foods and formula milk 6 hours. So this administering clear fluids at least 2 hours before surgery helps to decrease risk of hypotension. It decreases hypoglycemia, thirst, hunger, sensation. The patients are going to be more cooperative, and their intravascular status is going to be maintained, and it's also a part of the enhanced recovery after surgery. So this protocol that we call it the old protocol, it is a good, it has good safety in terms of low aspiration and regurgitation, but it has a cost of excessive fasting and distress. So recent publications have employed more liberal, that is a 1 hour fasting for clear fluids with no evidence of increased aspiration or regurgitation rate. So this is actually endorsed by the different societies, like in Europe, in Australia, and in some parts of North America. They have started using clear fluid administration 1 hour before surgery. So where did it start? There were different studies done in 2012 in Switzerland. They they have tried to see the effects of sugar clear fluid on gastric volume, and by measuring the residual volume and gastric empty using MRI. And they showed that administering of 3 ml package of fluid, clear fluid intake, the residual volume returned to normal within 16 minutes. And then there was also a study in 2015, still in Europe, where the gastric pH and residual volume was compared after administering of 1 hour of clear fluid and 2 hours of clear fluid, and it concluded that there is no difference in the residual volume between the two groups. They have tried to put energy and investigation for residual volume, and they say there is no difference in gastric residual volume. And it was also shown that in elective procedures, when children aspirate clear fluids, the mortality and morbidity is relatively small when it is compared to the adult population. However, in the United States of America, they are still sticking to the 2017 AEPS guideline, where it states that clear fluid should be administered 2 hours before surgery. On the other hand, on the European Society of Anesthesiology in 2022 have developed a guideline. So they say healthy children, they are encouraged to drink clear fluids up to 1 hour before anesthesia for elective procedure. And breast milk can be hours, and solid foods, it can be allowed until 6 hours. And light breakfast or solid or non-clear fluids may be allowed 4 hours prior to anesthesia induction. So where are we? What are we practicing? We are still sticking to 2 hours clear fluid fasting mode. But in real time, this 2 hours fasting guideline is actually, it means that it's more prolonged fasting time. It's very common for us to see children being fasted for clear fluids more than 6 hours, and even it can reach as far as 12 hours. So which one? Okay, so which one should we be accepting? So accepting a 1 hour liberal clear fluid policy may not be applicable in our country. Some places like yours, which has already started a 1 hour clear fluid policy. But for the large other parts of our pediatric hospitals, we may not be able to practice that one, but I strictly recommend at least to stick to the 2 hour clear fluid policy, where we can improve the general perioperative outcome and also be safe on the side of different complications. So the other one is pediatric regional anesthesia. Okay, so as we all know, pediatric regional anesthesia is an essential element of perioperative care, and it should be considered in all children undergoing surgery whenever it's over. And it has a high safety profile. This data is actually from the Western, and where ultrasound is used, and whenever it is the local anesthetic that is used it has a high safety profile, and it can be done under general anesthesia in children or in deep sedation. In addition to that, it has opioid sparing effect, and it has different benefits on the immunology, and the autonomic and metabolic systems. It also reduces the dose of general anesthetic that is used. So we can use it as a sole anesthetic agent, or we can use it as a combination with sedation. So in children, all kinds of blocks and regional anesthetic techniques can be used that we use in adults, except of course for there is an obvious contraindication like sepsis or infection at the site or blockage, increased ICP or whatsoever the contraindications are. And whenever we are doing blocks or other regional anesthetic techniques in children, we need to be able to appreciate the difference in anatomy and the physiology and pharmacology. It should be appreciated, and according to that, it should be given. So the spinal anesthesia in the wilderness is the main or the popular anesthetic technique for premature babies who undergo inguinal tracheography. They use it as a sole anesthetic agent to decrease the risk of apnea that is related with general anesthesia. We can also use it for different surgeries like for rectal biopsy, for access, for circumcision, any lower limb surgeries. It can be done under spinal anesthesia, and especially in neonates and children, it has an advantage of cardiovascular stability because of the very nature of children, because they have smaller venous capacitance that is used fully of blood in the venous system, and their predominant autonomic nervous system is parasympathetic nervous system. Therefore, their blood pressure is now mainly dependent on the vasomotor tone. So what are the controversies around pediatric regional anesthesia? The first one is to perform blocks under AWAKE or general anesthesia. So performing a regional block AWAKE or with minimal sedation in children, you can imagine that if they are not cooperative, especially at the age less than 8 years and greater than 1 year, it may result in child distress and movement during block placement, and because the nerves are so superficial and they are in good proximity to the different organs, it can easily result in trauma to the major organs. So different societies, for the American and the European society, they recommend performing pediatric regional anesthesia under general anesthesia or deep sedation, except for those who are neonates. It has an increased safety, and it is considered to be the standard of care. The other common question is that it could mask the pediatric regional anesthesia, could mask a compartment syndrome. It masks the early sign of pain whenever a compartment syndrome occurs, but up to date, there is no evidence that it will mask compartment syndrome or it increases any compartment syndrome, and it doesn't also delay its diagnosis. But for those patients who are really at risk of developing compartment syndrome, we can actually have an extra cautious and follow them and follow the pressure as well. So the other controversy is pediatric regional anesthesia, usually causing new or worsened neurologic deficits, usually when it's associated with local anesthetics that are used. For this as well, there is no evidence that supports pediatric regional anesthesia. It's indicated in pre-existing neurologic conditions. However, whenever we are trying to do regional anesthesia in neurologic deficit patients, we should be able to record whatever is happening in the pre-operative period. And even in patients with neurological conditions, when they have an associated cardiac or respiratory function being affected, it is said to be advantageous in optimizing anesthesia, minimizing opioid-related ventilatory impairment, and hemodynamic disturbance. Okay, so the other one is enhanced recovery after surgery protocol. So ERAS protocol is a multi-modal perioperative care pathway. It's designed to achieve early recovery after surgical procedures by maintaining preoperative organ function and reducing profound stress response. The benefits of ERAS has been there in adult population for more than 2 decades, and since 2016, ERAS protocols have also been started to be developed for the pediatric population. So what are the advantages of enhanced recovery after surgery protocols? It results in 30 to 50% reduction in the length of hospital stay of the pediatric patients. It also decreases cost and post-operative morbidity and increases patient satisfaction. And for ERAS protocol to happen, a multidisciplinary team is necessary, and we should be looking at the whole aspects of surgical journey, including the preoperative, intraoperative, and post-operative period. So I apologize for the clarity of this image. It's trying to show the components of ERAS protocol, the 21 components in the preoperative, intraoperative, and post-operative. This is usually for adult surgical patients. And in the preoperative, it includes like readmission counseling, optimization of different medical conditions, avoiding prolonged fasting, avoiding for preparation, and administrating non-opioid analgesics. In the intraoperative, it includes a standardized having a standardized anesthetic protocol and perioperative which management, thromboembolism prophylaxis, antibiotic prophylaxis, minimally invasive surgeries like laparoscopic surgeries, avoid intraperitoneal drains and unnecessary energy tubes, prevent hypothermia, and post-op nausea and vomiting treatment in a multimodal way. And post-operatively, it includes early oral nutrition, early mobilization, and early catheter removal, and to be able to stimulate gut motility, then opioid analgesics, and also optimize glycemic control and adult audits of the compliance and the outcomes. So the argument has been there for against the enhanced recovery after surgery in pediatrics. So the arguments against ERAS is the perception that there is less need to improve outcomes in children because of their very physiologic condition, and they have better physiology, and their baseline morbidity and mortality associated with surgery is lower. So people making that in pediatric surgery, we may not need ERAS protocols. And the other one is their heterogeneity. Pediatric age group is very wide. It starts from premature neonates up to adolescents. So their heterogeneity in age and also their physiological development hinders direct comparison with that of the adult population. And the other one is there is also still lacking a high quality evidence in adopting ERAS protocols in different institutions and different elements like thromboembolism prophylaxis in pediatrics population is questionable for different components may not be accepted in pediatric surgery. So the other one is some people may say the art of medicine is being lost by different protocols. There are already so many protocols in our working environment, and it will further diminish the skill and the decision of the clinician. And some also may say it may reduce operating room efficiency. It may have longer drug, and some may think they are already implementing ERAS protocols or certain types of ERAS protocols. And the other thing is there is also a concern after discharging the patients early. They may come with complication and it increases their readmission rates. So what is the argument for ERAS in pediatrics? In 2013, they compared the outcomes of 34 children undergoing elective major pulmonary resection for IBD to adult cases from another referral hospital. They have matched the pediatrics with the adult ones, and they have seen that the total length of stay in the pediatric group was found to be significantly longer than their adult counterparts. So this is just an initial, it may not be a strong evidence, but this is one study showing the ERAS. The other one is they with 5 pediatric studies that has been conducted in the United States over quite long over a long period of time, and they conducted a survey of also pediatric surgeons. They have asked them which elements of the ERAS protocol will be applicable in pediatric regional in pediatric ERAS. And generally, after the meta-analysis, they have suggested there is an association with a decreased length of hospital stay in the those following the ERAS protocol. They decreased narcotic use and no related complication. And after also the interview with the pediatric surgeons, they have included 14 parts of the enhanced recovery after surgery elements that most surgeons think that they should be included in the ERAS protocol. But for the remaining 7 elements, they have suggested further study. So these are the 14 elements in the green that should be that the pediatric surgeons thought it should be included. So use of mechanical bowel preparation, prolonged fasting, and all this should not be included. So this is a component we can try to use application of ERAS. So the other thing, unique patient populations like the neonates, they may like here. So further data is needed for this kind of population. So where are we? I haven't came out with any published evidence regarding enhanced surgery in the GAM report, both in pediatric surgery or in general surgery. So there is an ongoing research, but we don't know how the outcome is going to be. But how is it applicable in low resource settings? There are some data again in African settings, the majority being in South Africa, and they have demonstrated that it could be applicable in the low resource settings where the components are somehow being modified for low resource settings, like including safe checklist lists and like that. Okay, so this has been my objectives of presentation, and these are my references. Thank you.
Dr. Glenn for a nice and elaborate presentation. So Dr. Glenn has tried to address, I feel, some of the most important points which good physicians are made. So it does not require much resource to implement a strict rigid clinical guideline. It doesn't require significant resource to improve level of anxiety and the other issues also. So most of these areas we try to implement them on and off, but it can be applicable for our patients, but there are several pitfalls. So before I open the session for discussion, I will leave if you have any inputs outside of the presentation from the anesthesia team in pediatrics anesthesia care.
Thank you. Maybe I have also presented it last time regarding dextrose management. So I really like to emphasize on dextrose because as a physician,
Intraoperative dextrose.
Intraoperative dextrose management. So you might think pediatrics, of course, they require dextrose without dextrose management, but we need to be strict on how much dextrose we give intra, because as we have discussed previously, there is a surgical stress increment, which will increase the counter-inflammatory hormones. So high likely the patient might be hyperglycemic intra. So we need to be sure. We need to have specific indication for dextrose management. So better to give steroids as a part of bolus and to replace the dip. If we need maintenance for a specific group of patients like neonates below 48 hours, malnourished children already on high flow dextrose, premature kids, kids on CPN. For these kids, we need to, and also for those who have extensive analgesia. Sometimes in a place where I practice, we usually give adequate analgesia, IV analgesia, cauda, everything is in. So since there is adequate pain management, there will not be sympathetic rise. So the patient highlighting might develop hypoglycemia. So when there is extensive analgesia, those are some of the indications for intra-dextrose management. Still, the intra-dextrose management should be between Europeans, they do between 1 to 2.5%, US, they do 5%. So still for us, better to do 5% or even 2% works really well. So we need to emphasize on intra-dextrose.
Even for those who have like risk of hypoglycemia,
Yeah,
usually the maximum limit should be 2.5, but we usually stick to the 10% initial and
yeah, because this intra-dextrose, it might look simple, but high dextrose gives to osmotic diuresis, dehydration, for premature even the level of causing intraventricular hemorrhage. So hyponatremia, those things might work also. Make sure that hyperglycemia has also its own complication.
So we come to the discussions. Now I will do the floor for this session. So if you have any questions.
Thank you very much. That's a very nice presentation. Few comments maybe for us as well. I usually think of those guidelines like 6 or passively say a patient shouldn't be feeding for less than 6 hours or shouldn't be taking clear fluids less than 2 hours. We don't take it in the reverse order, saying that the patient should be on a clear fluid up to 2 hours of the surgery. We don't usually focus it that way. This is something that I have got from today's presentation. I don't know if the anesthesia team would encourage the children to give clear foods which have some sugar in it up to 2 hours of the surgery. We usually tend to make them go for a very long time. That's a very good insight that you have given us, because we already know it, but from a practice perspective, I think we put our patients more of on NPO rather than on giving them fluids. My question would be, especially with regards to the responsibility, who should be doing it? Who should be following that this patient is pre-medicated and that the management of anxiety is done, or this fluid is checked whether the patient has been taking this fluids and so on. And of course, it's going to be everyone's responsibility, but from a practical perspective, who should take them?
So maybe
Should I answer or I
Yeah,
answer?
proceed.
Okay, so as you have already mentioned it, I believe that
Can have-
everyone.
perfect understanding.
Everyone should be here. So it's everyone's responsibility, I believe. So it needs a multi team approach. So as by nature stage or this is we evaluate usually pre-operatively children at pre-op clinic and at wards. It's a limited amount of time that we encounter with the parents and with the children. But if we can work together, it's possible. It will involve the nursing staff at the ward that should also be involved with. And in doing those things, we need also follow up. We are not just going to pre-medicate children, or we are not going to introduce some behavioral intervention method, and we are not going to give away. So we need to have a follow-up mechanism as well, whether these things are working clearly or not, in terms of preoperative anxiety, or in terms of it could be also fasting guidelines. We need to have a well outlined journey for the patients. And there are different, I think, side effects of our institutions, usually our ORs and our wards are at different floors. And the nurses or whoever is there for following the patient, they are not well trained about following this patient pre-operatively for different guidelines. And we need also equipment to follow these patients properly. So it's going to need lots of teamwork and also resources and allocating people. It's not like it's not a difficult thing to do. It can still be doable. We can use our resources that we have, and we can try to start somewhere, pre-medicating these children using appropriate fluid guidelines, and we should also review our outcomes depending on our intervention. So it's a multimodal approach, and we can use these techniques for that on how to start.
I think since we usually practice in Q hospital, so for clear groups, we usually write the order, anesthetists will write the order, so the nurses will carry out the order. So when the patient arrives to theater, we will sign in the nurses will sign in, so we make sure the patient in the clear group 1 hour before the surgery. So anesthesia took the lead to write the order, but nurses will carry out the treatment. The other thing is the pre-medication, as Dr. Blaine said, someone should monitor the sedation. So some basically midazolam or ketamine. So someone should monitor the patient after we give them those medications. So most of those medications are anesthesia medications. So either anesthesia team or nurses should follow the patient. So when it comes to cure, we give pure midazolam or IM ketamine with midazolam sen. We will monitor the patient. Once the patient stands there, we apply the persistency and we do the patient. So I think the nurses should understand the importance of giving the patient treatment 2 hours or 1 hour before surgery. But first, they should understand the importance of giving fluid at least 1 or 2 hours before surgery. So that the order should be under anesthesia.
The reason why I say this is because we know it from his own perspective. We know it enough, but practicing it, we know that it's a somebody should be teaching or pushing this, because unless we start pushing it, won't come into practice. As you say, the nurses, the doctors, you know, the environment is very unhelpful, and patients, not only children, even adults, will be fearful of the environment, of the way we communicate, and so on. So I think bringing this to an issue, and it's not only the anxiety, even pain, cost of pain, it's not a big issue for us. So I think bringing this into picture and pushing it so that the anxiety, managing anxiety is it's important. It should be from the anesthesia partners, such as my co.
I think simply most of pediatric patients will come to that with IVD. Most of them. So if they arrive with IVD, you can give small analgesic dose of ketamine, so the patient will be calm, you take to the theater. I mean, that's easier with this one. I think everyone will.
Where does that fall?
Anesthesia.
Pre-medication.
Pre-medication.
It's a halfway for pre-medication. Normally, what we have seen in the Western centers, they have a nuclear area for pre-medication. So they will give them pre-medication after they are admitted, and they follow them. And when their OR time is, they will be going to the OR after being monitored, given for pre-medication. They may be given needles, which is PO medication. It can be like 30 minutes or 1 hour before surgery. So for that 30 minutes or 1 hour, they are going to be monitored in the waiting area. So then they will be transported to the OR. This will have a calm and avoiding of preoperative anxiety. But what we do is we don't have that free of the pre-medicating area. So in the waiting area, we just give them iron ketamine or IV, which is something, but we are not still there. So as the doctor gave something, we should be taking as well as it, and we need also use support to
Maybe, sorry, regarding the AEPS, there are several issues to science, but the first thing is respecting the schedule we have. So we have a schedule, but we are not sure which patient we operate early in the morning because of several reasons. One is we have ability to adequately give our patients, but there are other several logistic issues. Some patients may require an ICU, some patients may require medical surgery. Even our materials usually are available early in the morning. So these several issues result in flexibility. So better on sticking to the schedule we have set. So this is the major issue. Otherwise, the other thing is not difficult, and the other guests are also related. So we need to feel that prolonging AEPS is a source of anxiety. It's also especially you need to address it also. So they were thinking,
thanks so much. Enjoy remember is very strong. And 2 days ago, we're gonna what? Now it's a good start. Because we're not only suffering that in a safe way, but we are not that. So yeah, remember it's still very, very small, but we need to order, especially you now to do this. Otherwise, whatever training which we are giving to the available down the bottom of my students, minimum progress or minimum. At the end of the day, what we are trying to do is give a better service, better outcome, that means we are simple. So I think I'm happy to see you guys taking this responsibility. Regarding the issue which you raised about sedation and also patient selection, which the scientists mentioned about as a decision which patient to come first or second. I think, elective surgeries, we even know beyond in other countries or in other countries, but here, we even know what we are going to pay Monday after 3 months on elective. It's a booking system. So I think what is done in other parts is there is a pre-operative meeting every week, once a week. So everybody who's stakeholders in this, because we have said surgery is teamwork, the anesthesiologist, the surgeon, the operating nurse, the ward nurse, even the ICUs, they gather together and they discuss their next elective surgeries. So they decide, what to do, what is the procedure going to be done. So everybody will be on board. So how long to pass, which patient to need sedation, which patient need antibiotics, which patient need ICU, is ICU ready, and what kind of instrument is needed, the scanners are ready, everything. So I think this kind of trend will reduce this disparity and becoming surprised when the patients at the table discuss about that when after innovation. We tried that sometimes that we succeed, but I think you guys should now work together, because it's very also unusual to see surgeons and anesthesiologists, because both of them they work together. One cannot do without the other. But in the previous time, there were two rivals. Even sometimes they were not in talking terms. Everybody wants to see the next muscle. You have to operate, or it has to be cancelled instead of science. So I think this I'm happy to see in my age this being converted now, having a smooth discussion and working the discussion towards the safety and improvement of the service. This has to be continued. I hope now it will be another opportunity for you to have this kind of the weekly meeting, discuss the next week sessions, and everybody come to the same line on the way forward.
Thank you.
Okay. My question is on the environment. I think one of the issues with the spinal anesthesia was the dosing, how much to give for children. So how are you going to do it? And how are you going to prevent complications which will most of them how do you do that in pediatrics?
So in pediatrics, we can use spinal anesthesia, as we say, for different procedures. So even in when for they did it for extreme 3 months. So the dosage is not going to be the same as
What is going to be our?
It's going to be dependent on kilograms. So for those less than 5 kg, 1 milligram. From for less than 5, 1 milligram per kg, 5 to 10, 0.4, greater than 10 kg, 0.3 milligram per kg. Which vaccine can be administered, but because of their larger volume, then the duration of action is going to be shorter. So either we need to use other anesthetic techniques combined with general anesthesia, or we may be using this one for only selected procedures. So in neonates, the advantage is that they may not need that much sedation. We can just place them in that position and use needles in the hair line. So it's going to be identified. We're going to use that, but the duration of action is going to be short. Because of their physiology.
What about the preloading?
Preloading? No, we don't need preloading. We just keep a normal volume of. They need to be followed intraoperatively with monitoring, with health rate, with normal monitoring or monitoring will be there. So we don't have to load in pediatric patients. We just give them training strategy as for initial starting point. This is the advantage of spinal anesthesia because their ventricles are not well developed and there won't be pooling of blood in the periphery. So they will not respond to hypotension unlike that of adults. And their predominant nervous system is the parasympathetic nervous system. So they will not be relying on their vasomotor support for cardiac output. So even for cardiac surgery, they can be they have to use spinal anesthesia.
Cardiac patient, no cardiac surgery.
Yes.
I mean, there's a case we have done during my fellowship. The patient is large obesity, probably that patient having going there. So for this group of patients, one gives us spinal, so the patient is taken. Hemodynamic disturbance that from the spoken to adults before the whole the reason she has mentioned parasympathetic predominant venous capacitance is not like adults, so no need of even bolus. In US, even I've seen they secure the evidence after the spinal because the patient is numb, so it's easy to secure the evidence on your extremities. This extent, the modern disturbance is not common pediatrics.
Any other children who supplementary is sedation.
Yeah.
What's that?
But for neonates, you may not need that much of
For
sedation. But for other words, even general anesthesia or in some certain instances,
Actually, that was my question too. On the issue of sedation, is it just for until the regional anesthesia is given, or should be continuous throughout the course? Because patients might be agitated, irritable, and so on. Still, that might cause distress. So, is it? It's not actually also. It's recommended to give sedation, but is it throughout the course? Because my reading is most of the patient has to be still on continuous sedation as a for intravenous or some other choice of drug. What's that only just for until the regional block, because technically it might be difficult. So that's the first question. The second question is regarding to the clean fluid. Actually, do you have special protocol that you define as clean fluid? Because what's clean fluid in the textbook, there are different fluids which are written as clean fluid, but in our practice, it's different among surgeons and students and so on. So, do you have specific things? Because that's really very important to practice. Because we have seen, administrating clean fluid for some setup institutions, which is far from the most advanced, like Blackland. It's now, but we are practicing a refined type of anesthesia practice. But in some other areas, it might be even a surprise to give food for 2 hours and they will operate. And states may even argue, you might cancel the patient and so on. Because these kind of things have to be promoted to such kind of continuous medical education. That's one thing. The third thing is practically, personally, I have implemented induction, parental presence during induction subprivates. With some of the procedures. And it's even in a compliant family who can understand us better, interesting and so on. It's still difficult. From my observation, there was a patient, the family who was lost during the procedure. So, you have to really give awareness to the family and so on. So this even parental presence during induction might be might give you the reverse. So that has been considered also in the research. I think it's very difficult in our maybe in some of individual patients, I mean, who is very caring to their kids and so on, there might be some sort of individualized decision, but it's very difficult in our context to implement such kind of guideline. So this is
Which maybe stands out in the duration of the patient.
That's your interpretation? Yeah, I
Maybe
mean,
in anesthesia.
based on group of patients, I mean, when you have a premature kid, the reason why you want regional anesthesia is to avoid GA, because it will decrease the risk of post of apnea. See, with spinal anesthesia in unit, there is a risk of apnea, but compared to the general anesthesia, the risk is very low. So you don't need, I mean, there is a paper on pediatric regional anesthesia. After you give the spinal, there is neuronal differentiation, which the patient will be seated after you give the spinal, especially in units. They don't get anxious, especially in small kids, in premature kids. For this group of patients, even what we did is, I mean, small precedent. We don't have in our setup. What we have is relatively anesthesia medication, which keep patients spontaneously breathing is ketamine. So you might give small dose of ketamine. Otherwise, for units or prematures, once you give your spinal, the patient will sit and you don't see that anxiety. But for infants, some age groups, they might be anxious. In that group, you just give mild sedation. The idea of giving spinal is to avoid general anesthesia. So by the time you reach deep sedation, it means, general anesthesia without unprotected airway. So the aim is to avoid deep sedation, the aim is to avoid general anesthesia. So you can't do mild sedation with a small ketamine infusion. You don't have presidex here, you don't have midazolam. If you have that, then you can proceed with spinal anesthesia. So it's called like neuronal differentiation, where the patient will get the effect after you set with spinal anesthesia. Regarding the grapefruit, there are fruits there. For example, tea, coffee, non-pulp containing like grapefruit, what's called apple juice. You don't give juice that contain pulps like orange juice. Well, with tea, coffee is possible. Gum is impossible, I know it's contraindicated because the patient might swallow the gum and this aspiration. So grapefruit, when you say it includes tea, coffee, Coke, apple juice, you need to avoid orange juice. Sorry, group of grapefruit. So if you want to use that grapefruit protocol in a place where you practice, you need to write the indicated contents where you can give for the patient. So the issue of anesthetics not accepting that issue, it's personal. I mean, yeah, that's the problem. So if you inform them or have a group discussion in a place where you practice, it's good to have small discussion with the anesthetist, with the surgeon, with the nurses. So you explain them the importance of giving food for the patient. If they understand, I mean, that's the most important thing for the patient, because once you start the surgery, if they're being collapsed, getting IV line is also the most difficult part for a patient dehydrated, anxious child. So then the time the patient will collapse in the middle where you are looking for IV line. You start your routine looking for IV line, the vein will get collapsed, then even you might lose the patient. So the advantage is most important.
This trend actually changing. Professor, we have seen it. So previously, the surgeon wants to operate on anesthesia team was considered the concepts. Now this has changed. So discussions are based on scientific ground. And I think there is significant stride we have made, significant important, and it can reflect the different centers. No.
Thank you. Thank you for the nice presentation. So I think as a pediatric surgeon, it's very common to see our patients being like saying, I'm not willing to give the operation factor. Plus, relatively, we do have also issues in the post-operative area too, because of pain, because of other things. So the things that are raised today might have significant impact if it's really applicable. So what are the challenges of implementation is the things that we need to consider. So culture change is not an easy task, and it's multidisciplinary, and it has to be engaging with a good vision and also a positive attitude. than just pushing to implement it. So there might be issues around knowledge, there might be issues around resource, there might be issues around flexibility and also knowing what is really happening in the block. So how can we collaborate? The feeding issue has been raised at different times, at different scenarios for all undergraduate and postgraduate issues. We all know the science, we all know the impact, but it has to be changed. So the fact that you guys has been done in the Western system has shown you there is a trend change. So why not here? We have been doing pediatric surgery for more than 20 years. We have been starting pediatric surgery training for more than 7-8 years, but still we are there. So why do we not change? So if we have to change, definitely the nurses has to be included, the patients have to be included, advocacy has to be done. And what engagement, so as an anesthesia provided, yes, we mainly need people in the OR, but we don't always need the OR. We also want to go and teach and also show the impact as the work. So how can we collaborate? Is there any video session we can share? Is there any pamphlet we can share? Is there any other ways of training? What would be the solution we propose? So Q can be an exemplary site that should can share with us how they changes the culture, but it doesn't have to be always putting the current in a system change. We have to be there putting our own systems. As Black Line, a major teaching center, we have to start so we can share the experience to our police in Ethiopia. So we don't have to the early services. We have to set up our own strategy and change the culture. Not only on the feeding, pain management, PRS, anything else. So maybe the spinal in
Can you experience
I would like to.
Okay, thank you. So, yeah, Lily, you have
A good point that we have started, we have made this education and we have raised the issue. This is a good starting point, first kind of discussion, including the nursing team and for ORT should be there and further discussions should be there. I believe that will solve, that will be the second step that should be taken, and then we should be also able to develop our own curriculum and share it with the board team. So that would be the next afterwards in such small steps that we will take.
maybe you have a practice of MDT? Because I feel like one of the ways is in a hospital is to have an MDT, but then you are asking, how do you practice MDT? And or not outside, but here.
So whenever such incidents may happen, we may come together and discuss over it, but we don't have such a regular one. So that would be a great input as well. We should be having such a either Wednesday or it would be decided by the board.
The most important thing I would also want to emphasize on pain management, as Dr. Kuntuna said. So post-operatively, what we have is, nursery inflammatory drugs. So opioid, there is a reservation with regard to giving opioids. Nurses, even surgeons are afraid of ordering opioids. What we give is diclofenac, trauma to ibuprofen. So multimodal analgesia is very important. So that's why patients next time they come, they will be anxious. There's the risk of chronic pain syndrome later on. Those certain surgeons we need repeated procedures. So pain should be emphasized, and the caudal at least, I understand in most setups, spinal anesthesia is not practiced for pediatrics. Minimum caudal can be done. Because there are some papers, for example, patients with colostomy, simple colostomy for infant tetanus, you might need colostomy. The patient might have big vasectomy as a part of, the kind of complete AV canal. For this group of patients, even you can't do the procedure with caudal analgesia. Minimal sedation, then caudal, at least minimum. You can't proceed like that. So pain management is the most important thing in pediatric patients. So please try to focus on pain management. Even regarding opioids, if you want to give more feed, start with very smallest dose, you can start. Even ketamine post-operative analgesia. I mean, the problem in our setup is we don't have well seated PACU. Even our ward doesn't have a monitor, let alone ward, even PACU doesn't have adequate monitoring. So minimum, it's good to have oxygen source and the pulse oximetry. If you have no pulse oximetry and oxygen source, we can give you opioid. So you will see the patient with the patient is breathing, the saturation is maintained. So pain management should be emphasized. And as a pediatric surgeon, wherever you practice, try to set up your PACU at least one bed for one pediatric surgeon, well equipped with oxygen source and pulse oximetry, because most of complication will happen in PACU, like respiratory arrest, even cardiovascular complaints, respiratory obstruction, stridor, all those things happen in PACU. So when you focus on in the theater, you should also emphasize on PACU setup specific for pediatrics.
It's just following on the same issue. We have different scale in the majority of the setups. Now, it's just a study of generalized, other than and the problem is because the spectrum of the anesthesia professionals in Germany. Now we are talking what we have to do when there is anesthesia. But in many of the setups, even on pediatric anesthetics, the problem of general anesthesia process. So I think this issue has to be also with other professionals. And I wonder some similar lectures when they have their national society, something like that. Or you have input in their development of training. Because like, for example, in our setup, in the Indian institution, we have been doing the actual setup for the past 7-8 years. But still, in many of the organizations, anesthesia, even more than toilets, are even by instances. And even in the country, I don't know, so I think this was important and also but it's going to be quite a long time for what aspiring.
Yeah, I think it's a valid comment. So when we think of anesthesia practice, especially pediatric anesthesia, as a nationwide, so we are the only ones who is giving pediatric anesthesia care, especially in rural settings. It's not alone, it's not even in urban settings. So we should incorporate the training to the different anesthesia providers. We actually do informal teaching at different OR tables or in different encounters. However, that's not satisfied at all, and we should think of different teaching sessions. Because when we think as a country, we should incorporate that.
Yeah. Questions? Comments? Our time was.
So one thing I want to say, I just put the idea of, in our hospitals, we have a few pulse trainers in cure. So if some fellows in pediatric surgeon or even pediatric surgeons want to train in pulse, there might be an opportunity. So it's good if most of pediatric surgeons go to training in pediatric advanced centers.
Yes. For example, is it possible to send somebody resident or still a resident or maybe one of the senior athletes to be
So I mean, for yeah, first, if you can communicate with the hospital, so they will arrange. So and then one of our pediatric surgeons that cure. So we give we are pulse instructors. So for pediatric advanced. So you can communicate with the medical director. So they will arrange the training for 3 days. So everyone should know how to resuscitate in pediatric specialty. Because in a rural area, for many reasons, patients are not stable. So everybody should have a knowledge of how to system.
That's what. It's nice stuff.
Thank you.
Thank you, everyone, for the session. But I should not leave this session without appreciating the Anastasia team for their presence, but particularly Dr. Wood and Dr. Blaine for committing to care for pediatric surgical patients. I know pediatric surgical care is emotionally and also physically demanding, and most have been avoiding in engaging in pediatric anesthesia care. So you have broken the ice, and now hopefully everyone will come on board. I know it's a rocky boat, but thank you for sailing with us. And photo.